Well, today we have to talk about something very fun, actually, because we're trying to talk about something that's healthy and fun to do. So something that's healthy for you and fun to do, putting those two together don't happen very often. So that's actually good news. So I've been asked to talk about the public health implications of 3D viewing. And that's where the big prize is here. And that's what we want to bring forward to talk to you about today. So as we move forward, I want to start by saying something that's a little bit radical, but it's true. And that is 3D movies have a new dimension. And that new dimension is protecting eye health. And so what we're going to do today is talk a little bit about how that fits into 3D movies. And I hope to go through a few things that will help to do that. And my goals today, in order to do this, is really to describe the current vision and eye health needs and gaps in our society today, and to highlight the clinical basis of the transformative opportunities in 3D vision. And you know, we need transformative opportunities at this point in juncture in time. And then to suggest what the first public health steps forward might be in this new continuum. Now, in order to do that, I want to take you back a bit, because this is kind of where it really started in terms of the intersection between optometry and 3D vision. You're going to hear later from other speakers that will talk about the 3D vision part of it, but I want to talk about the preventive aspect of this. And that is that in 1850, the Snellen eye chart was developed. Has anyone seen a Snellen eye chart? Any of you? A few of you. Okay. And that was developed in 1850. It was really the starting point for vision and eye health secondary prevention, or vision screening, what many of you think of today. And just let me ask a question, just out of curiosity. In the group here, how many of you had a comprehensive eye exam, were seen by an optometrist or an ophthalmologist before age 6? Any of you? Yeah, I thought my daughter would raise her hand. Okay, so about 6 or 7 of you, okay? That's not too high, is it? Let's take a look here. So basically, if we look at the nation now, and we look at how children get to care, we can see that they pretty much don't get to care. So by age 6, before I was with the AOA, I was with the Centers for Disease Control, and we were taught to tell people, in God we trust, all others bring data. So I brought some data here. This is the National Health Interview Survey 2002. And you can see that only about 7% of children are receiving comprehensive eye care prior to starting first grade. Now, many people in developmental theories will tell you if a child is behind at the time they start first grade, they may never be able to catch up. Just remember that. Now, why is it this way? What is our screening system? Is it a system? Some people might ask, is our healthcare system a system? But in this case, definitely this is not a system. It's a broken system, if you want to call it a system. So the way this works is children are screened. Are they screened? Well, they're probably at the pediatrician's office, maybe at the school nurse. And then there's an identification of a vision disorder. They actually use vision screening to identify the disorder this way, and then refer them to an eye care professional, an optometrist or ophthalmologist. So this is what we're currently doing. Now, how well are we doing this? Not very well. So if we look at the United States and we look at state by state, what are the criteria that we established by law to regulate this? And you can see the states in red are states that have no screening requirements whatsoever for vision. The states in yellow have screen and follow-up, screen only in tan there. And 3 states felt that comprehensive vision and eye care was so essential to their state population's health that they decided to make it mandatory that children in that state have a comprehensive eye exam prior to starting school. So that's kind of where we're at right now. Let's see how this works, or doesn't work. So vision screening is done by the pediatrician or school nurse. Guess what they use? Snellen eye chart, right? You've all seen those, okay? 27% sensitivity. Now, any other disease entity that we're screening for, if I told you that I was going to use a test with 27% sensitivity, you would laugh at me. You would say, that doesn't make any sense, okay? So, 27% sensitivity, what does that mean? That means that most of the kids being tested are being told that they don't have a problem. There's a high rate of false negatives. That means they're told, you don't have a vision problem, go back to your classroom. They go back home to their classroom. And what happens is they can't maintain focus, they can't read, they can't comprehend well what they're doing, and they fall behind. But the parents don't think about vision as the problem because they were told that their child passed the vision screening test. That wasn't a comprehensive eye exam. Those children, many of them are false negatives. Now, some of them go on and are referred. But let's see what happens in the system. In the system, 27% sensitivity, high false negatives, most of the kids pass. The few that fail have a problem. You have 99% specificity. If you can't see an eye chart, more than likely you have a problem. So, of the ones that have a problem, guess what? There's a problem here. Even the kids that fail vision screening with a standard eye chart, a new Baltimore study just showed that only 17% of the kids that failed ever got to care. This is a system that's broken. And in the broken system, we can fix it. And if you've been to one of my lectures before, you know I use fruit a lot. So I'm just going to do something here to help demonstrate this. All right? I'll tell you about that later. Let's take a look at the 3D world of vision and what this means to eye and vision health. I'm going to go over the basics right now.
In order for a child to develop normal 3D vision, the brain must receive clear and aligned images. This is most important during the critical period of vision development from birth through age 6. If one image is blurred or misaligned, the brain will learn to suppress that eye's image. This suppression results in a lack of development of vision cortical cells for that weaker eye. A condition called amblyopia or lazy eye develops. Unless discovered and treated early, this becomes a permanent vision impairment and disability. Amblyopia is most commonly associated with conditions that include misalignment of the eyes and unequal refractive errors between the two eyes. In rare cases, amblyopia may be caused by reduced vision as a result of a cataract, a scarring of the cornea, or a drooping eyelid. Once conditions are corrected, patching of the better eye often commences treatment. In order to perceive 3D images, the eyes must track together and remain precisely aligned at all times. There are many types of eye misalignments that cause loss of 3D perception. The eyes turn or have a tendency to cross in conditions of esotropia, turn or have a tendency to deviate outward in conditions of exotropia, and in some cases, one eye can turn or have a tendency to deviate higher than the other, with the higher eye being designated as having hypertropia. These misalignments may be due to insufficient action of one or more of the muscles, differences in muscle length, and or placement of the muscles on the globe of each eye. Fusion difficulties and lack of 3D viewing related to eye alignment can be intermittent, constant, or alternating, and can vary from mild to severe based on the amount of deviation between the two eyes. When light reaches a curved surface such as the eye, it bends. This process is known as refraction. The eye works like a camera with two main refracting surfaces, the clear outside surface known as the cornea and the lens located in the interior of the eye. Combined, these two curved surfaces work together to focus light onto the retina, a thin layer of tissue on the back inside surface of the eye. For 3D vision to occur, light must focus precisely at the same location on each retina. If the light focuses instead in front of the retina, the refractive error is known as myopia, behind hyperopia, and mixed astigmatism. All can cause loss of 3D viewing. Perhaps you've heard of computer vision syndrome. Eye strain from computer use has been shown to cause tired, sore eyes, headaches, blurred vision, and general fatigue. Although 3D vision has some similarities to CVS, the signs and symptoms of 3D-related asthenopia or eye strain are highly distinctive to the 3D environment and its unique demands on the vision system. Unlike CVS that affects almost everyone using a computer, 3D vision problems are only experienced by a select segment of the population, those that have underlying undetected and untreated vision disorders. The basis of CVS is that pixels produce images on computer screens that constantly change and cause the eyes to continually refocus. The demands of 3D are far more specific, dependent on precise tracking, alignment, balanced and clear focus, and stereo perception. Together, these provide important opportunities for secondary prevention or screening of vision and eye health. New disease prevention and health promotion 3D activities, beginning at the earliest stages of vision development, will soon redefine how we uncover subtle eye problems while they are still amenable to treatment. Additionally, just as special coatings are prescribed to reduce unwanted glare in CVS, special 3D vision glasses will soon incorporate refractive error correction and prism to modulate and reduce eye strain on individual muscles. And don't be surprised if eye exercises are in order as well.
So let's see how this relates to school readiness, okay? So the important thing here is that 3D vision and the ability to see in 3D also relates to how well a child can learn in school, to read and accommodate to the types of demands that they have in education. So these factors are tremendously aligned to success in school. And they're one of the biggest factors of how well a student can learn. 80% of learning is related to vision. So undiagnosed, untreated vision disorders are highly prevalent in our society. Approximately 25% of students in a classroom, in any given classroom, need some sort of help. And if you look, not many of them actually have it. So also, if you think about the cost associated with this vision impairment, correctable vision impairment, by the way, if caught early enough, it's staggering. Also, we know that from adults' interview survey questions, we know that most adults say that they don't get eye care because they have no reason to go. 60% of adults over 40 say that they don't receive eye care because they have no reason to go. That's kind of interesting since all of the conditions are asymptomatic that cause blindness and vision impairment. So what we're talking about here, the opportunity here, is secondary prevention. And that is techniques that find problems early in their course so that actions can be taken to minimize the risk of progression and transmission. Now, in this case, there's not transmission, but certainly progression. So we're talking about secondary prevention. Now, we talked about this in terms of new technologies coming on board, and you're going to hear about it because Nintendo is going to be releasing next week, actually here I think in the United States, the 3DS game. And in actuality, we want children younger than 6 to use it because we want to be able to pick up amblyopia and these problems earlier in their course of the development so that we can treat them and prevent them. The interesting thing about amblyopia, these diseases we're talking about, they're preventable. So what we're doing with 3D vision is moving this forward so we're picking up disease earlier when there's actually an area where there's typically no symptoms, and here we're developing a system where we can actually use and produce symptoms that cause us to identify disease and problems earlier. Basically, we're taking lemons, making lemonade, and curing scurvy, in this case, curing eye disease. So if we use this properly, what we're going to be able to do is we're going to increase sensitivity to over 42%. If we do it correctly, we can get much higher than that too. We're going to have lower rates of false negatives. We're going to be able to tell people specifically what kinds of kids need to go for care, and we're going to get them to the right care. We're going to fix the broken system. And how we're going to do that is a stepwise approach. We have a paradigm that we work from, and we're almost there. We've described the problems. We've done the analysis. We're beginning to translate it, and you're going to see policies develop because of this. So, and then once we do the policies and we collect more data, guess what? There's a feedback loop, because we might need to do it a little bit differently, but we're going to do it much better the next time. So, the way we look at it is, it's a tremendous opportunity here. And we've come a long way to this point in time. And we believe that in order to, we can go fast and do it alone, but we're going to go together here with this consortium and a collaboration to move us forward faster. And we can move a lot more forward since 1850. Now, if you're wondering why I threw this over here, if you know, I noticed in New York they sell a lot of bananas on the street. Has anyone seen banana stands? Mm-hmm. Yeah. But you notice there's never any banana peels on the ground. Isn't that odd? You know why it's not odd? We've been taught to say you shouldn't throw banana peels on the floor because you might slip on it, right? Well, guess what? Because of the asymptomatic nature of vision disorders, kids and adults slip into vision problems. And it's not, they don't know it. So, just like we pick up banana peels, we're going to have to teach the public, if you have symptoms with 3D, you can go have an eye exam, and many of those symptoms can be treated. Thank you.